Thank you for having us here today. I want to thank the Ohio Academy and its leadership. I also want to thank the Ohio residency programs for participating today. We're really delighted to share with you some information and insights about the Family Medicine AIRE initiative. Joining me today, I'll be your facilitator. I'm the program manager for FM AIRE. I work for the American Board of Family Medicine Foundation. And sorry, there's so much red, white, and blue. Those are really our colors at the ABFM Foundation. This is not an extension of the election season. So we will try to minimize those colors a little bit later on. But joining me today are really two terrific family medicine leaders who run residency programs that have added their programs into the AIRE initiative. And I'll have each of them introduce themselves. Stephen, I'll ask you to introduce yourself first.
Yeah. Hi, everybody. Steve Osceola. I am the program director here at Riverside Methodist Hospital Family Medicine Residency within the Ohio Health System in Columbus, Ohio, and thrilled to share a little bit more about our work with you today.
Joe, I'll have you introduce yourself.
Hey, good to see everybody. My name is Joe Scaraya. I'm the program director at the Oregon Health and Science University Family Medicine Program in Portland, Oregon. Thanks.
And right before this call, I found out that Joe fell in love with family medicine in Ohio, in Northwest Ohio. So has some Ohio roots there. So Joe and I and Stephen have a few disclosures, but mostly we care about GME innovation. We're voluntarily involved in this project. This work is sponsored by both the ACGME and the ABFM. And we're delighted to be able to extend this work and share it with family medicine. Our agenda today, we're going to touch a little bit about how we got here. How did we get to the place where we created an experiment around GME innovation, particularly around length of training? We're going to spend a lot of time on the AIRE initiative itself. And just to remind everybody, AIRE stands for Advancing Innovation in Residency Education. And we put our own little twist on it. We put an FM in front of it. So it's Family Medicine AIRE that gives it its own sort of unique brand. We're also going to talk a little bit about the destination and the implications for the AIRE study. And we're going to spend a lot of time on addressing your questions and giving you some insights from both of our GME innovators. So just a little history lesson here for those of you who may not have been involved at the beginning of the creation of family medicine as a discipline, but as early as 1964, when we were contemplating what should family medicine residency education look like, there was a debate going on, and there were 3 national reports that sort of described what family medicine could look like, then family practice. And you may be surprised to learn that in the Willard report, which was initiated by the AMA, there was a notion that residency program and residency education should be 3 to 4 years in length. It sort of was not defining it as clearly as we do today at 36 months. And then back in 1988, some folks started to kind of think, what should family medicine? How are we doing after our initial ideas that were created in the late 60s? And then some colleagues and friends, Marguerite Duane, Larry Green, other folks in the discipline did some studies and really learned that there's some opportunities for us to examine length of training. And at that time, there was considerable interest in understanding what should residency education look like to meet the needs of society. And that fundamentally is the question that has sort of established this initiative and the others. The interesting part, when you map out training in family medicine across the globe, it's really quite variable. In fact, it's really variable. It goes from 2 years to 6 years. And for those of us involved in this project and others, this really brings out a lot of curiosity. Like, why is it that it's 2 years in Canada? And what outcomes do they get versus why it's 3 years in the United States or 6 years in another location? What goes on there? And so part of this process is trying to understand that and see what those variables are that are important. So back in the early 2000s, there was a call for a period of voluntary experimentation that at least lasts a decade. And I think family medicine has been up to the task during that time. So there has been multiple projects that initiated with the P4 project. P4 standard for preparing the personal physician for practice. It's when I started getting involved in these studies, and it started in 2007. And we've had several additional studies and initiatives that have examined length of training, including the length of training pilot, some national graduate survey data, things of that nature that have begun to, again, continue to have this conversation about what is the right length of training. Better yet, how best to prepare graduates for the contemporary needs of society. I think the other thing to point out here is the Starfield Summit back in 2020 and 2021 really set out to ask, again, these central foundational questions about family medicine. Stephen, will you talk a little bit about this?
Yeah, so starting off with a little bit more of the background information, kind of the current state of the learning environment, and leading into some of the why we might want to consider participation in this initiative. I think what we see in observations, I certainly see this as a program director, is students having more shadowing type experiences and working less general hours than they did even a short time ago. I think certainly COVID brought some of those changes and amplified some of those changes. So we have students who are maybe not getting as much of a consistent hands-on experience in their education prior to joining us in residency, and less adapted to working some of the longer hours that physicians may have done in the past. That's coupled along with an ever-expanding scope of our biomedical knowledge, that medicine's getting exponentially more complex, and the ability to continue to acquire new skills along the way requires continued innovation and adaptability to meet the changing needs of your practice. The ABFM continues to emphasize a movement towards competency-based medical education and really making sure that we are focused with the end in mind of trying to make sure that the outcomes of our training are not necessarily linearly followed, but are adapted to each resident based on the activities and abilities that we can document that they can achieve for excellent practice. What we're seeing from medical students and residents is they really want that flexibility and options in their training. Students choose family medicine because they want that flexibility and adaptability. Family medicine gives us such a broad reach of what we can do in our careers. And I think students are really attracted to those options. And it's one of those things that I think we have an opportunity to capitalize on, maximizing that future flexibility and options to continue to keep those idealistic medical student goals captured through residency education and into their future career. And I think lastly, we need to meet the needs of the communities that we serve. That as a family medicine workforce, I think this work was really amplified by the most recent ACGME updates that really gave a little more flexibility to programs to meet the needs of the communities that we serve, and know that programs in one area may have very different community needs than programs in another area, and that us as a family medicine community have the most flexibility and adaptability in our training environments from one to another to really meet those unique needs.
Thanks, Stephen. Now, Joe's been involved in a couple of our experiments over these last decade or so. And so could you talk a little bit about some of the learnings that you've experienced or point of views?
Yeah, Jay was just sharing that this picture comes from just like how we looked at innovation many years ago. And we have been through several rounds of innovation, as Jay has outlined, but the direction of next steps isn't totally clear. I mean, those of us in the length of training pilot thought we had it all figured out and we had this information to share when we were done, and that we were going to be changing things. But the answer is we need more information. But family medicine has stepped up to the plate. I think when programs have gotten involved with things like P4, I3, the length of training pilot, what we've seen is that we can scale these ideas, that there's actually a lot of community to innovate, and to be innovative with the way curricular design can be, which is something that we have felt, and that perhaps 4 years is a model, and we hope that there's some amongst you who really are excited about this, to help think about how we reshape kind of what Stephen laid out previously, which is, students coming in, less prepared than maybe a generation before, and less opportunities during training because of good things like duty hour restrictions and work week restrictions, and less procedures available, but they're finding careers that lead to an increased scope of practice for family medicine, and in turn, a decreased level of burnout. And so there are a lot of ways to do this. And, there are programs that have done this now for a sustainable period of time with funding, and we'll touch on that a little bit as well. But I think there's an opportunity here for us to continue the learnings from the past.
So one of the barriers for advancing some of our innovations over the last couple decades or so has been the difficulty in measuring it. And so there has been an evolution of that in educational research over the last 20 years. And that is making it easier for us, if you will, to engage and understand through an empirical process what the outcomes of our work are. And I think when I think about Judy Pauls, and some of you know Judy Pauls, this notion that how can our clinics or our residency and teaching practices really model what can be out there and change the healthcare environment. Sometimes our teaching practices sometimes feel like it's at the mercy of the environment, the financialization of healthcare, for example, when in reality, I think some of our innovators feel like their teaching practices can change that environment. And so that's where some of their hopes lie. I think it's important for you to understand as you hear more about AIRE, about the general timeline of the AIRE project. So it's really 3 functional stages. There's initiation, planning, and execution stage, and that all kind of runs together. We have a rolling application process that runs from 2022, which both Stephen and Joe have been early on in that process, through 2026. So if programs are interested, you have some time to kind of work out the details that you're thinking about. We hope to have about 70 family medicine residency programs in the initiative overall, and that's significantly more than some of the other prior studies, which have been pilot studies. I was involved in the P4 study, and we originally had 87 submissions of ideas around GME innovation. And at that time, that represented about a quarter of the family medicine workforce. But unfortunately, because of funding, we were only able to study 14. And so FM AIRE ends up being a really important scaled study to understand what we should be potentially changing about our discipline and about residency education. From 2022 to 2032, that's really the period of study and also the period of implementation. So Stephen and Joe, they've already started doing this. And I think, Stephen, you're about ready to have your first graduate. Joe, you may have even had your graduates already. So we have graduates who are already going out, and we're studying them along the way during this about 10-year period or so. And then it's estimated that in about 2032 to 2034, there'll be a new set of requirements for family medicine. And the work we do today, the investments we make today, will inform those outcomes and those policy decisions. To learn about AIRE, there are 2 places to go. We have a new Family Medicine AIRE website. You can see this, that it's at fmaire.org. On that website, we have a background white paper, our application criteria, and we'll soon be launching an application portal, which will make that application process, which up until now had been pretty much a paper sharing via email, which Stephen and Joe had to do a lot of work on that. We've simplified that a lot thanks to their efforts, and we appreciate that. But one of the things that's super important to this work compared to previous studies, oftentimes those previous studies, it took 5, maybe even 6 or 7 years for those results to emerge and become actionable, if you will, by the discipline. We plan to do this real time. As Joe and Stephen learned from their particular innovations, they will be sharing this with the discipline, either through publications, events, but also on our website. So please come back and look at FM AIRE frequently and often, because we will be updating the discipline on what's going on. ACGME originally started the AIRE initiative. Again, they have this for all disciplines. We have a version of it called FM AIRE. So you can read more about the broader AIRE initiative by going to their website. And either way, you can contact an ACGME representative or an ABFM representative through the websites, and we are coordinated. So the ACGME representative is Kate Hatlick, and she and I meet on a regular basis to coordinate interest in the program.
All right.
So Stephen, yeah.
Oh, go ahead. Yeah, I'll jump in here just to describe a little bit more about the types of initiatives that are currently in AIRE. This has been categorized into two broad categories. One of each is represented between Joe and myself here. So for the first category, these are programs that are interested in offering both 3-year and 4-year training pathways, not making every single one of our training pathways 4 years. So our program is part of this, and what the general structure is programs that will offer a start of some type of longitudinal pathway that will extend into a 4th year of training, typically starting in that 2nd year. So providing a longitudinal scope of training alongside the traditional 3-year pathway. There's a wide variety in what that can be. It can be a fellowship type experience. It can be aiming towards a certificate of added qualifications or advanced degree. It can be taking a program's strength and expanding beyond that to really give an added area of focus to something that you may already do well, or give some space to residents who really want to do added skills that may be beyond what is easy to fit between those 3 years of training. And I think another thing that comes up is that decompression of training, as training can be so condensed in family medicine, and we're trying to train for such a broad skill set, giving residents the option to choose, does a 3-year pathway make sense to them, or are they really invested and engaged in a 4-year pathway to really get the most out of their residency innovation? I'll flip it over to Joe for the other side.
So, you know, we on the other side, I'll let Jay kind of move that forward there. All of our residents who come in, so we're a 12, our residency size is 12 per class. And I will say we were 12 per class when we were a 3-year program, and we expanded to 12 as a 4-year program. But for us, it's everyone who walks through the door is a 4-year resident. And then what that leads to is they have the same continuity panel for all 4 years. They spend most of their time in the 3rd and 4th year with their continuity panel, what happens in the 1st and 2nd year as well. But there's a fair amount of flexibility in that 3rd and 4th year, though we've got kind of themes of generalism through all 4 years. There's flexibility in that 3rd and 4th year for the resident to design or to initiate interest in what they want to develop deeper skills in with that generalist platform.
Joe, you do a lot of different innovations in your particular project. Can you talk a little bit about some of the opportunities to think about innovation in GME and how to think about it?
Yeah, Jay, you know, I think one of the best things for our program about length of training, pilot, and AIRE is it really allowed us to tap into the bench that we have. So really highlighted faculty expertise, which I think what Steve was talking about too is like really think about the strengths of your program. For us, we had folks who were doing a little bit of all of this, but it allowed them to create a platform for their career as they moved into teaching this at a deeper level, but then also attracting residents who wanted to do it more and find new things. I mean, I remember, you know, 12 years ago sitting with somebody and he was going to spend all his time ultrasounding people in the ER. And I thought, gosh, what a waste. You know, you're never going to do this in the outpatient setting. And now he leads our curriculum, but it allows for kind of passion areas and depth to happen within programs, sometimes in ways that we don't know. Like for us, hospice and palliative care is internal medicine based in my institution, but their fellowship director approached us. So what it allows for is for faculty to shine, but for you to attract faculty. And then what happens is you attract these residents who want to do this work, and it flourishes from there. So it really kind of helps you build on your strengths, but in some ways find new strengths as well.
Joe, before I move to the next slide here, and we talk a little bit about Stephen's sort of innovations that they're working on at Riverside, can you talk a little bit about the importance of fundamentally using advanced family medicine as the core of your innovation so that you're not creating mini specialists, if you will?
Yeah, that's, you know, what AIRE allowed us to do, that onerous paper process that we went through for Jay, it was actually good for us because we got to really define, you know, what is it about family medicine that we love, that we think is important. And it was the ability to be that first point of contact that was the most important thing. And then from there, we built out, there are these skills we expect of our learners and our community of physicians to be doing, and allowed us to think about scope being the most important, that anyone could, these doctors would not be, even if they were on the hospice and palliative care track, would not be afraid of seeing a pregnant patient in their office or admitting them or know what to do, on a night call just because they had interests everywhere else. So it's really important for us, and we stress that through our building of the curriculum, that there is inpatient all through 4 years. There is continuity clinic through all 4 years. They take L&D call for all 4 years in some form or fashion. That is actually really important, because we didn't think, when we looked at what our community needed, they didn't need subspecialists in Eastern Oregon. They needed family docs who could deliver, that family medicine plus. They could deliver family medicine, but there were additional things that they could bring to their community. So that's how we've thought about how we shape this curriculum.
Thanks, Joe. Stephen, I'm going to turn it over to you to share a little deep dive into your particular innovation and what you're doing at Riverside.
Yeah, thanks, Jay. So I think you're going to see a lot of contrast between these two programs. And I think what I'm trying to represent is the new group to this and that 3 versus 4 years. I think we're still very early into this. I'll defer a lot of the long-term outcomes and the learnings we hope to get eventually to Joe over there. So I am at Riverside Family Medicine in Columbus, Ohio. I really want to thank our kind of core leadership team that's listed here. We couldn't have done this without Jen Middleton, who has really driven this project both spiritually and from the work to really get us to where we are here. And our program faculty, Dr. Gase, is doing an absolutely wonderful job creating the structure behind this and continuing to build this out. So what we offer is a leadership area of concentration that extends starting in PGY 2 year, going through PGY 4 year. This started as building off of something we thought we already did well. We are a 666 program, and when I looked back over the last 10 plus years, we were averaging about 2 of our 6 residents per year going on to some type of dedicated teaching and academic positions. And another observation that I had is it's really hard to get meaningful, useful feedback for new faculty if they go directly from a residency training environment to a teaching environment. And we saw an opportunity there. I think there's a lot of ways to describe what this optional pathway feels like. People ask, is this a fellowship? Is this a TY year at the end? Is this like just an extension of training? And it's a little bit of yes to all of those things. But what we really wanted to do is build out an innovation. When we heard about this FM AIRE initiative, we really had the desire to say, can we take something that we think we already do pretty well for most residents, and can we create a pathway that expands and allows us to do it even better for a select group of residents that really have a passion for what we already do well and do it better over 4 years? And then inform the national conversation as the, what we should do with the future of family medicine debate continues. We wanted to be a part of the program that's informing that role. So for us, we want residents to also have some flexibility and adaptability. The core experiences are set, but there's also a lot of flexibility. And how we have it structured is a little different than how Joe described there, where PGY 2, PGY 3 year fairly similar, 4th year functions a lot different. And we also wanted to explore competency-based medical education, so we could expand that in our program. So yeah, and go ahead and jump to the next slide there. So first of all, just applying the CBME principles. I know something that's been a conversation for us in the last couple of years. How are we going to adapt to competency-based medical education? We weren't prepared, but I saw this as an opportunity for us to really be able to inform this conversation. And one of the great things about pilot pathways like this is with a smaller number of residents, it is easier to be adaptable and innovative. What we had hoped in building this out is we were going to not only learn a lot about competency-based medical education, but have a space where we could trial things on a very quick level with a lot of those micro PDSA cycles and take those large lessons learned to our entire program. So this would be something that we were going to create some EPAs, some trustable professional activities, things that complement the core outcomes from the ABFM, really trying to look at how can we not only measure these residents in the traditional ways that we're measuring PGY 1 through 3s, but also measure them in other ways to really show what more can be gained over a 4-year pathway in comparison to a 3-year pathway. You can jump to the next slide here. So the PGY 2 and PGY 3 year for us, very similar to the traditional pathway in a lot of ways. The main way we have really focused on is now with the expanded elective guidance, we give our AOC residents a lot more structure around how we expect them to use their electives. And we really want to have longitudinal skill building throughout their PGY2 and PGY3 year in preparation for this PGY4 year. We're looking at when we can document achievement of our ABFM core outcomes. And this is still really something that we're in our pilot phase, having our first PGY2 residents going through the full pathway, really trying to understand how can we make this a unique experience for them. The biggest advantage is this transition into PGY4 year. That's why this is different than a fellowship. And I would argue that it is better than a fellowship because we don't have that onboarding period, that 1 year period. If you're trying to teach new skills, we get to flow seamlessly from PGY2 and PGY3 into that PGY4 year. It is a longitudinal schedule rather than a rotation-based schedule, mirrored like a junior faculty experience. I think its closest comparison is something like a faculty development fellowship, where you are functioning in that junior faculty role, both in the inpatient, outpatient setting, with progressive autonomy and that continued multi-source feedback, both from PGY1 through 3 residents and your supervising faculty, as well as a large time commitment that is structured and protected toward a unique area of interest. So I want every resident to go through this pathway. While we only have one small pathway and there's the core pieces of leadership and academic development, I want every resident to have their own unique skills that they can have that protected time to pursue, something that may be hard to build into the PGY1 through PGY3 experience or hard to get in their future career. You can jump to the next slide, please. There's a lot of information here. I wanted to leave this in just to show that there is a lot of things that we are piloting. This is a little bit of the phase of throw a lot at the wall and see what sticks, but we want to see what works and what doesn't. We want to try a lot of different types of evaluation and see which ones get us that meaningful feedback. We have a wonderful pilot resident, which I'll tell you about in a little bit, who is our first PGY4 here, who's helping us pilot this here. So yeah, Joe, go ahead and jump to the next slide, Jay. So, and I think Dr. Ringwald's on the call here if you have any specific questions for him. One of our biggest motivations is we had an absolutely fantastic resident who met the needs of what we're trying to build. And that was one of our motivations to really jump in early on, because this was a pathway that was tailor-made for residents like Dr. Ringwald. And I think this is an example of what it looks like in residence. You know, this is, I think, hopefully a testament to if you build it, they will come. There are residents and medical students that have an appetite for pathways like this. And what we saw with Dr. Ringwald is he piloted what we would be designing in the PGY2 and PGY3 years, and now has officially been able to step into this PGY4 experience. Is he trailblazed as a PGY2 and PGY3 in these skills and has taken that next leap as a PGY4. We have really been thrilled to watch his continued development in academic preparation and leadership. And we have had, with the expanded space in that PGY4 year, he has, I don't want to say run wild is a bad thing, I've run wild is a good thing with the areas of interest that he has. We have him serving on hospital committees, really building out this amazing educational portfolio, really plugging into teaching opportunities, and his special area of interest is scholarly activity, and he has embraced that. I think the current number is 19 accepted or submitted peer-reviewed journal articles just in 2024, so you'll be hard-pressed to read a family medicine journal that doesn't have something written by Dr. Ringwald, and I think he's invested in furthering this conversation as well, written multiple SARA surveys, and is an award winner at the national level. So if you do have any resident-specific questions, he is on the call. If you do plug any questions into the chat about, you know, why residents may want to do this, and you want a perspective that's not a program director perspective, he may be able to jump in and give you that added insight. Go ahead and jump to the next slide, Jay. We also have 2 residents. You know, we added this pathway in the middle of our program, you know, and none of our current residents knew that this was going to be something we were going to offer definitively until we had that in place. So one of the big questions is, if you create something like this, do residents and students want this? And what we saw is we had 2 residents who applied and were accepted into the full version of this. So this is our first path through the typical pathway. We had 2 outstanding residents apply at the end of their PGY1 year that have now entered the full pathway here. They've got really unique residency interests and ways that they want to serve their communities. And we're already laying out what are those projects we want them to follow throughout their PGY2 and PGY3 year to be able to fully embrace in their PGY4 year. Next slide, please. So a few common questions I wanted to throw out here, because I've gone on the roadshow both in the application process and in the convincing my hospital system and my leadership, and then doing that all again at least twice to try to get this off the ground. How are we funding this? We kept it simple because this is a fourth year that is a not fully funded year. So, while there is some indirect money that comes in, we left those out of the calculations and we kept it simple for our financial reasoning because, boy, I had a lot of leadership that was excited about this. When I talked about innovation and shaping the future of family medicine, they were less excited when I asked for money to support it. So I went into this knowing that I had to get this off the ground and we had to drive this work without asking for any additional funds. Because we thought that it was worthwhile to get this off the ground, showing that we can do this without an additional cost, even though in a perfect world, that would have been something I would have loved to advocate for. So we built out the longitudinal clinic schedule of that PGY4 year, looking at expected costs and revenue from outpatient visits and compared that to salary and benefits and designed that in a way where typical outpatient volume should at least offset the salary and benefits of the PGY4 year, may potentially be revenue generating. We haven't had a full year to cycle through and run those numbers yet, but we designed that where I'm hopeful that this is actually going to be something that's a net positive for our practice. Does this help with recruitment? So far, we think so. One of our PGY1s last year, an out-of-state outstanding student, says that this was one of the primary reasons he chose to come to our training environments because we offer this. So we know that family medicine applicants from United States medical schools are slowly downtrending to family medicine. We need to respond to the needs of those people who may be interested in a career in family medicine. And we think that these novel training pathways and these innovative pathways are things that are going to increase interest and recruitment. We have seen an uptick in our applications this year compared to last year as we've been part of this initiative. So I think it's a positive. Joe may be able to speak a little bit more to that than me, but we're seeing positive trends in that. Are residents currently happy in this? I think preliminary is yes. It seems like this is something that's really enriching the program. One of the things that I'm really seeing is Dr. Ringwald, our PGY4, is helping mentor so many other residents in scholarly activities. So I think this is going to be something where those PGY4s that are expanding on a typical program strength that we have are helping the rest of the program. So this is something that can benefit the entire program, even if you were to participate and not have every one of your spots changed to a PGY4 year. This is guiding a lot of our work in competency-based medical education. We have learned so much this year about what works and what doesn't. We're really excited to be sharing some of our lessons learned at the AAFP RLS this spring, at how we're taking the lessons learned from here and applying that to our broad program. And lastly, the why, right? I think this has already been captured, but we want to bring in the best and the brightest students, entice those students who maybe consider a career in family medicine to really say, hey, this is what the future of family medicine looks like. There's a lot of really exciting things happening in family medicine, and this is the field that you can shape that flexibility more than any other field. So I hope we can tell the story that because there's so many different ways to create these initiatives, that there's opportunity for flexibility and adaptability to meet the needs of your community and what you want in your future career. Go ahead, next slide there. I think, is that it for me?
I think that's it
I'll
for
flip
you,
it over
Steve.
to Dr. Sakaria.
All right. Go ahead, Joe.
All right. So I will kind of walk you through a little bit what our program looks like. I will say I came to OHSU at the time that the length of training pilot took off. So the decision was made. So I was not the program director at the time. It was Roger Garvin was the program director. Some of you may know him from his RPS consulting, and John Saltz was their chair, and they both strongly felt that we needed to do something different. And so being able to reimagine it with my team has been great because they're actually four-year grads that are my associate residency directors because they stayed on. They're part of the first classes that went through the length of training pilot. But we were able to sit together and for a month and a half, really just talk about what are our hopes and dreams for a program if we can do another layer of innovation. So OHSU is an academic tertiary care center. We are located up on the hill. We had considered changing our number, because we got a cohort of 36 that we could pay for, but early on the decision was to train 48 residents, and we maintained that as we moved into AIRE. So next slide. The picture here is funny because the class on the left is a class that I recruited under the length of training pilot, who ended up being eligible for AIRE, and the class on the right is who I recruited as a part of AIRE, but they're both equally excited as we've moved through this. So these are the first two classes. These are first and second year residents in our program, but they are part of the AIRE curriculum as they're moving through it. And so, just like, I think Steve is in the process of like, you'll have 3 people who never knew, who came in as 3-year residents, being in, exposed to the 4-year resident. We're having the same thing too, where there are pre-air folks and post-air folks, and they're mixing the two, but it's allowing for a level of innovation in the program that is fantastic, because the folks that weren't recruited under air are getting to try out some of these things and shape curriculum and even design curriculum for the folks under them. Next slide. So the big question, if you build it, will they come? You can go next slide, Jay. I went to Dante's 10th Circle of Hell, which is Reddit, and looked at what do folks say about us. And there are plenty of doubters out there. There are probably plenty of doubters on this call. What I'm going to share with you, I just finished all of my interviews, and I'm going to share with you some slides from the down the road about like what we've seen from the length of training pilot. But there's definitely questions about like, gosh, if I have this 4-year program, are people going to turn me off? Next slide. We know from the length of training pilot, though. So in the length of training pilot, there was a review group, and 3 and 4-year programs were paired, and they were located similarly. And these papers are coming out now. But they looked at, was there an effect on recruitment? And the deal is 4-year programs were not a turnoff to students. So students are interested, but what kind of students? Does this favor folks who are already wealthy? Jay, next slide. And so they wrote a paper on that. There's no difference in student debt burden, enrollment in loan programs, or pre-tax income. That was not a factor, at least when the group studied it. Next slide. So what has 4 years of training produced? Next, and we'll just quickly go through this. This is our ABFM graduate survey data. So this is from 2016 to 2023. You all have access to this data in your grad. So this is just, the light blue is us, the dark blue is the country. So this is what we're sharing with applicants as they're looking at our program. What have we seen with 4 years of training? So engaged in outpatient continuity care at high levels. If they're not, the few that are like end up doing hospitalist work. Next, Jay. What does a practice site look like? You get to the 50% mark if you look at FQHCs and academic health centers. There is a follow-up question, as y'all know, like if you're teaching, who are you teaching? Over 60% of our grads teach residents, over 15% are teaching fellows, and over 70% are teaching students. So like, I think being around this model, Steve kind of highlighted this, but like being around this model of innovation and teaching really does, I think, impact or imprint this for the learners that you'll have. So those are the folks you're going to attract into your program. Next slide. Besides your principal practice site, where else are you practicing? So over 50% also have hospital work. So they're practicing in multiple domains. And the 4 years, again, the space, what Jay kind of made me highlight in the beginning was like that generalist all throughout. This is what this has produced for us, that ability to constantly, yes, you have a continuity panel, you're taking care of them for 4 years, but you're going to jet out and you're going to do some intense OB work, but you're going to come back to your continuity panel. That what we're doing in 3 years, just maintaining that for 4th years, I think adds a level for folks. Next slide, Jay. And procedure-wise, what are they doing? And this is, again, this is what they felt prepared for. And next slide, like what they're doing in their practice. And one more, just click it one more time. It mimics a lot of what we did. There is a sense of the rising tide lifts all boats. I'm going to look at vasectomies, for instance, because we dedicated all of our residents to have dedicated vasectomy time. It actually opened us opportunities at Planned Parenthood where we're the only ones in town. The urologists have pulled out at Planned Parenthood doing vasectomies. It's led to a large volume of vasectomies for all of our learners. So this, like, even when some seem to be favored, it actually has elevated the conversation for all the residents in the program. So that has really been a benefit for us that I've seen directly in the time that I'm here. Next slide, Jay. So what does a length of training pilot produce? So we know that like length of training, like when folks are really looking out there and looking at grads, is another study that comes from that length of training pilot research group. Practice size, practice type, all that looks the same. So like these folks aren't being cherry picked to go out just to do academic work. We're not recruiting them all here at OHSU, where this is the only place where they're doing their work. They are going all over the country. But The reason why folks are picking practices that come out of four-year programs is scope of practice is important. I think the difference that we're seeing in the scope of practice that people have, and this is a research question we are asking currently when we're going through AIRE, we think there's a little bit of space to breathe in between in the 4 years while you still have to hold on to that continuity panel that you've built over your first 3 years as a resident, that allows you to think about what you're willing to negotiate and what you're willing not to negotiate. And we think that is happening. And salary isn't the motivating factor for these folks. Like, it is, scope of practice is really meaningful. Next slide, Jay. Other question, I think Steve highlighted this, was like, okay, how are you paying for this? Because we all know, we've all been to Alan Douglas's lectures where we're not getting more money from CMS for this. So it's like, we're just getting 3 years, but how can you pay for this? Well, there's more resident visits at each level when you look at the 4-year programs. This again comes from the length of training pilot, where we looked at 4-year programs and 3-year programs. More visits at each level. And then next slide. And then speaking of the aforementioned Dr. Douglas, he put some folks together to look at what are the different training, like funding models in the length of training pilot for these 4-year programs. The big piece here is, on average, 4th-year residents average about 1,000 visits in the outpatient setting. This is what we've known from the length of training pilot. So actually that has funded for a lot. We were a little bit different. When we started out, Kaiser Northwest Permanente approached us when they knew that we were doing this thing, and they were willing to pay $115,000 per resident per year. They paid us. We gave them residents. They got 3 per class. We had a continuity clinic out there. So they had 12 residents. It paid for the expansion of our program. But for us, that contract ended, actually. But we learned a lot as we were at Kaiser. They were able to, so they, since 2016 on, as soon as this was announced, they recruited additional faculty based on all of our residents that went out there. So not just the 12 were there, we sent all 48 there. But also, like, as they were putting this together, folks wanted to be academic and work at Kaiser to attract those folks. We know that 12 resident cohort in that clinic covered 3,000 additional lives. And in a year, they got 7,000 visits. So when our partnership is ending with Kaiser over the next couple of years, we turn to our FQHC. And what does that mean for an FQHC that gets an alternative payment methodology that they could cover 3,000 patients, that there's access for 7,000 more visits in a year? It was a no-brainer. It was easy to say, this is going to fund itself. So we are funding it with what our 4th years see. But that has been, like, that story that we've been able to tell has been really important. So this is fundable. This is one way to fund it. Another way, there are other ways to think about it, but like, residents, like, and especially as they're learning from that practice and engage with that practice, you know, my 3rd and 4th year residents see what my faculty see, actually. Like, there's not much of a difference as far as numbers. But it's the skills that they're developing that's really good. Next slide. So this is, you know, Jay laid out kind of the timeline. This was our timeline. As soon as the announcement for AIRE was announced, we met internally and we debated, and we've got lots of drafts for our proposal that we put together and redrafted. And in the middle of all that, Jay introduced us to Ventura Family Medicine Residency, who wanted to do what we were doing. And so then we started meeting as a bigger group. And then we had like our HPM fellowship director heard about it at her national meeting and wanted to know if we were thinking about being involved, if she wanted to be involved. Our sports medicine fellowship director wanted to create family doctors who did sports medicine, but like weren't team physicians all the time. They wanted to create family medicine doctors who did sports medicine in their community. So it just created this opportunity for us. And we built our consortium, which we're calling FIRE, which is Fellowship Integration to Residency Education. I'll have a couple slides on that. But that is how the momentum that we got from being together, thinking about this, really plotting out that secret sauce of what is family medicine was really important for us as a leadership group. It was really reinvigorating for me. So, you know, for us, there's 5 pathways in our program. One is, the first one, comprehensive family medicine, is the way our program exists right now. So residents have modifiable time in their 3rd and 4th year that they fill based on where, like, what we try to do is hold a mirror up for, like, if the mirror is their community, what skills do they need to meet the community that they're going to practice in? So, like, we want them to be thinking that much into the future as they hit their 2nd year, and then carving out these experiences to reach it. And that has worked for some of our residents, but we think that the other 4 tracks, based on what our strengths are and what we're able to do, these take up the space of that modifiable time in the 3rd and 4th year. So that is their elective time. and we fill it with this. There's 2 that are ACGME accredited, and those do lead to a certificate of added qualifications in sports medicine, hospice, and palliative care. So at the end of their 4 years, they are able to sit for those 2 boards. Next slide. And this is, when you're putting your application together, you put together this logic model. And so we just kind of put in like what we think the innovations that we're going to be doing. And it has just been a great process to go through this. I think this as a faculty exercise to define who you are, where you want to go, what do you want your residents to be doing, has been just invaluable for us. Next slide. Yep.
Yep. Thanks, Joe, and thanks, Stephen, both. So we wanted to go ahead and shut the slides off a little bit. First of all, thank you for all of the questions that you submitted in advance. That's really helpful to us, and we've kind of taken the liberty of folding those into the next section of our presentation. But if you have other questions that come up or have come up because of Joe and Stephen provoking you with some new ideas that you have, feel free to post them here because we'll field those too. So let's see. Oops, I gotta stop sharing my screen there. There we go. Okay. So one of the key questions that I hear a lot is what's in it for me? Whether it's a resident saying that, or whether it's a program saying that, or sometimes a sponsoring institution. So what in your experience, Joe and Stephen, have you kind of talked about folks when they kind of give you that what's in it for me question?
Yeah, I'll jump in. I guess I'll approach it from the resident standpoint, because that's where we're still mostly focused on the kind of the early points here is, I think for residents and the what's in it for me, I think for us being able to offer both a 3-year and 4th-year training pathway, it really is focused on capitalizing the flexibility of family medicine. And, I think pretty much every person I interview for training spots, and you talk about why family medicine, what attracts them to family medicine, it's that flexibility and adaptability and being able to create the career that they want. I think more and more we have less residents just wanting to say, I want to go through the typical pathway, just join a practice and not do anything else. We have people that are focused on how can they maintain their well-being, how can they find meaning in work, how can they adapt and change and grow throughout their career. And I think this model just aligns so well with where learners who are choosing family medicine want to do that. Whether it's an every 4-year spot or a 3 versus 4-year, it offers expanded flexibility to that skill set that they wanted to develop. And I think they recognize that there's a lot to build into 3 years. While that may be the right pathway for some, I think 4 years seems like a really good pathway for a lot too. And I think the residents and the students really see that. And I think even when they get to residency, they really see just how busy that time is, that those 3 years just fly by. So from a resident standpoint, and what, the story we're trying to tell is that this is really a pathway that can offer that expanded flexibility to help them customize their family medicine education a little bit more.
Joe, I'm going to ask you to share a perspective because you brought in some of the feedback that you get from students who definitely don't want this, right? And who are fairly willing to share their opinion on social media. But so, you've kind of addressed already, will students join us for GME Innovation? You've been at this a long time. What's your experience as students' perspectives, largely about innovation in general, and if you want to call it innovation or new ideas or promising practices, whatever that is, what sort of experience do you have and how do you address that with students and others?
Yeah, it's a lot like everything. I say there's not a one size fits all for this, meaning my 4-year program is not for every student interested in family medicine. It just isn't. You got to want to do all of it. So I'm speaking to a specific subset within family medicine that really is like bothered by the scope of family medicine as it exists, thinks that there are niche skills they'd like to develop, and want to do it all. So that is who I'm hoping to recruit. And I'm very honest with applicants as I say that. So what I tell them is there are excellent 3-year programs out there. Just like if I have someone who comes and sees me and says, I really need to be in FQHC. And in our system, we've got 5 clinics, one's in FQHC. Well, I can't necessarily guarantee. If you need to have that, there are excellent programs that have that, and you should seek those out. So I really try to speak to what our grads do. This is what we're recruiting for. This is what we're training for. If this is of interest to you, come and join us. If it's not, it's really okay. And because you don't need 4 years of training if you don't want, if this isn't appealing to you, the breadth at least. So that's how I've approached it. I'll say one of the things for us that has been good, not just on the applicant side, but on the faculty side, at a time where I think as a faculty, burnout feels like it is increasing. This is rejuvenating to be able to and it gives meaning to the work that our faculty do when they're really able to take their passions and they're attracting learners, and there's space in a learner's schedule to be able to engage in that. That has been really beneficial for us as a program, is that really rejuvenates our faculty. They are wanting to be engaged in this.
Stephen, I'm going to even riff a little deeper into this question. You've had to recruit, if you will, residents into your new innovation. And so how do you talk to them about debt and loan, potential repayment, and those kinds of issues? Are those issues that come up in your conversations?
Yeah, absolutely. I think, the opportunity cost of an extra year in training needs to be looked at from both sides. I think we've talked a lot about from a program side. From a resident side, we have to convince residents that an extra year of training is worth it in the long run. I think one thing that helps me with perspective is the majority of fellowship opportunities that family medicine grads go into are not necessarily drastically changing their long-term income. They're changing their scope of practice and the things that they're doing in practice. So, this is not dissimilar to many of the other reasons why people are already choosing to do extra training after finishing family medicine training. They're expanding their scope, they're identifying the things they want to do in their career, and they're doing it. And there may be defined pathways already to get those skills, but what if there's not? Or what if they have multiple interests and they don't want to do 3 or 4 years of fellowship? I think these pathways give people an opportunity to do a custom fellowship like experience, and with the lens of innovation, where us as a program, we can deviate from some ABFM and ACGME requirements. I mean, that's part of the application, but that's one of the selling points. That was one of the most exciting things I heard about is, ooh, if I'm in this, I can potentially get some leeway from some of those ACGME requirements, which luckily we haven't had to do much of, but having the flexibility to be able to do that in the sake of innovation really allows us to shape that future pathway. And, I think people get really excited about that. I hope that for us, this optional pathway of every single person that goes through it leaves with something different. I don't want anyone to just do the same thing that the last person did. So I think that is a compelling argument for a lot of students. Again, I agree, not every student. This is not the right pathway for every student going into family medicine. But for those who are looking at 4-year pathways, that selling point of, hey, I can really, I have a lot of career interest, I have a lot I want to do. Am I really going to be able to jam all of those things into 3 years? And could I decompress a little bit to maintain my own well-being and purpose and take care of myself over that time, and be able to get those added skills that they really want in there? I think it's a compelling argument, and I think what we've seen is people are entering these pathways too. So I think that a common question is that opportunity cost is, why not just jump into practice? But I think when you look at the other opportunities in the 4th year, it aligns very well with what people are already doing.
Yeah, so my next question is there one really sticky, stubborn problem that you weren't sure you were going to be able to navigate in order to get into AIRE? So for example, Stephen, we know that when you first submitted, we said no, right?
Yes,
we said, gosh, that's interesting, but it doesn't fit within our scope. So could you guys share sort of that sticky, stubborn stuff that you were able to solve?
Yeah, I think that's fresh for me, so I'm happy to jump into that one. I mean, I think we had several roadblocks along the way. I think most importantly, I'm really stubborn, but I also had a great team, and I think we had a really aligned vision. I think we were really focused on, hey, this is an opportunity that really makes sense for our program. We pulled our faculty and talked about this, and we really had a supportive group thinking, hey, this is this seems like something we really should do. And we had, if you're on the call and you're thinking, wow, this seems like a lot of steps to get from not participating to participating, I think I really want to call out Jay for being such an amazing support person through this. And even when there was some roadblocks that came up, it wasn't a sorry, no thanks. It was a, hey, here's some feedback, here's some things, let's have another conversation, let's work through this, because we were brand new to this process. We didn't have links with other programs. This was just something that we were driven by the things that we heard about this program. And what we found is we had a supportive network that we were welcomed into. We were given support along the way to help us kind of revise, make sure what we were proposing was going to be consistent with the goals of the FM AIRE initiative. And also there was a lot of hurdles on our side. Getting a complement increase request through a large health system is not an easy process. And what we found is we went through that whole process, then we got the ACGME approval, and then our system process changed and we had to do that process again. So I got to jump through those hoops twice. And I can say it was not an efficient process and there was a lot of hurdles along the way, but it was well worth it. So I think the end in mind and getting to this point, looking at the hurdles that we jumped through, I'm really happy that we were persistent with some of the barriers that we encountered. And I think if you are interested or toying with participation, I really want to just call out how wonderfully helpful Jay has been and the support provided by the American Board of Family Medicine to really emphasize the importance of contributing to this conversation. It's been work that was well worth it. And it really, to build on what Joe said, it's been engaging for our faculty. This is something we've got many of our faculty that are really excited about, that is driving some of the purpose, bringing back a lot of that joy to the residency education.
Thanks, Stephen. Joe, what's been kind of sticky, stubborn problem that you've been able to surprisingly navigate?
Yeah, well, I think we put this together, everything got approved, and then there was a question of would these folks be able to sit for their CAQs? And Jay knows, but we were, and this is the beauty of being a part of this innovation, is Warren Newton is very interested in this innovation, and you get to sit next to him at meetings where we're talking about the problems that we're going to encounter, and he helped us solve that problem. He reached out to the folks in the other boards to talk about, like, hey, we're doing this. It's going to be the same amount of time. We're not going to sacrifice training these folks. It was really a champion for us. And so the nice thing is that in these innovation spaces, I think there's access to a lot of folks that are really interested in improving family medicine and really can lead it. And it raises the conversation in your program. I haven't run into a problem that I haven't gotten a solution for, honestly. Like, there's always a way forward, and because you have access to the right people.
Yeah, thank you both. So we're kind of running up against time here, so I'm going to just make another quick announcement. If you have other questions, feel free. This is your last opportunity. In the meantime, I have one question that's on our docket that I'll ask Joe and Stephen. And what surprised you so far about this work?
I can jump in. I think the opportunities really surprising. There's stuff that we do in our own echo chamber in Portland, and the opportunity to partner with Ventura and just that ability to reach across. For example, we're going to be David Araujo, when he was program director, and I went to the ACGME for that 5-day course around assessments, but we're running our own assessment course out here in Portland with Ventura. So the ability to partner outside of the organization has been good for a lot of reasons, but it really kind of elevates what we're doing. Even when I'm talking to my own faculty, Ventura is going to be involved with this, raises the conversation. So this opportunity to partner across, with folks that you otherwise wouldn't have a chance to.
It's great to see Ventura and Oregon folks get together at our learning sessions, and they're like working deeply on exchanging ideas. So that's been really great. Thanks, Joe. Stephen, what's surprised you so far?
Yeah, I mean, I second a lot of those things about the collaboration opportunities have been great. I think the thing that surprised me, one of my fears jumping into this is that this would be more work when we're already really busy. We're already stressed. We're already stretched thin sometimes. Healthcare is already a stressful place to be. So we already have so many stresses. Was this going to just be one more stress that we would regret participation in? I've just really been relieved at how this work is so complementary to what we're already doing that in many ways it aligns so well. It doesn't feel like extra work. It feels like work that's honed in a direction that's helping us improve our program. And it's not only giving that meaning and purpose and that excitement for those that enjoy innovation, but struggle with the means of how can we do this within the constraints of a typical environment. And it really just gives you an opportunity to create something unique. If you are energized by creating unique things like I and many people in my program are, and we've got an amazing faculty that have driven this work, it really has felt like it hasn't felt like there's been more work this year in this than there has been in previous years. If it's felt more like better direction, better aligned work. We see that why for many of the changes that we're making. And I think the work we've focused on our PGY2 through PGY4 pathway is just really easily aligning with what we're already doing as a program and giving us some direction. And, I'll go back to, it's a lot easier to make changes for some residents. So if you're thinking about that both pathway, the 3 and the 4th year pathway, we can be so flexible with what we're doing for, a handful of residents that it's not an overarching program change every time we want to change something. So it is a little bit of a kind of special innovation grounds, and you're probably selecting out some of your highest functioning residents who are going to get you really meaningful feedback. So it's been a very positive experience. I have not experienced that. I have not gotten to this point thinking, wow, there is more work that can be achieved now. If anything, it's just been better aligned work.
Thanks, Stephen. I appreciate it. And I appreciate both of you for sharing your stories about your experiences in AIRE. We thank you a lot, and thank you for the kind words. We're going to end here with just a final slide. I want you to know my cell phone number. And it's a little bit like giving your cell phone number to a patient. In my case, I want you to use it. If you're thinking and worried about this in some fashion or form, if you got some ideas, call me. I work across multiple time zones, so call me whenever you want. Text, call me. Happy to talk to you. If I don't pick up, I'm busy, but I'll be happy to call you back. But please do so. If you're pre-contemplative about this, that's okay. We can talk about those kinds of things. We can connect you to other folks. Joe and Stephen both have their email addresses up here. You're both welcome to write them. Most of our FM AIRE applicants are very willing to share not only their application process as well, but also the very specific artifacts that go within that process. So this is really a great deal of transparency in this initiative. And this is really in contrast to a lot of other projects I've been on where it's almost competitive in nature. So please feel free to do so. Applying, you can apply as an individual program, but increasingly we are having interested programs who want to apply as a consortia. Multiple programs who kind of want to do some of the same things and want to figure out how to work that through the process. So you can also, again, coordinate with me to do so. If you do contact the ACGME by chance instead of me, that's okay too. Kate Hatlick and I will connect with each other, and you may be surprised if you reach out to Kate that I'll call you. And so I've got more time than Kate does, so I'm helping programs do this work, and I appreciate the opportunity to visit with you.